So, so good evening, everyone. So, with this, I welcome you all to this 14th educational series of Apollo Mumbai Critical Care Learning Network. And today is going to be very interesting sessions of tropical infections by our eminent speaker and followed by the panel discussion by all the eminent panelists. And I request all of you to make this session very interactive and put all the questions at the end of the talk so that we can take one by one questions and have discussion on this. Specifically, all the exam goers, the DNB fellows and the critical care fellows, I request them to participate and make this session interactive and interesting. And with this, I just start with the introduction of today's program and the speaker. So today we have with us our eminent speaker, Dr. Sagar. Dr. Sagar Sinha is the Chief Intensivist, Critical Care Physician and Emergency Physician, MGM Hospital, Navi Mumbai, and he's the, I think, Associate Professor, working Associate Professor there also. And he's one of the prolific speaker, and particular interest area is basically the tropical infection. So that's why we are glad to have him here. And with us, my colleague, Dr. Akhilesh Tandekar, consultant intensivist, Apollo Hospital, Navi Mumbai. So he'll be one of the moderator. Hi, Akhilesh.
Hello, Dr. Gunadhar.
Yeah. So and with us our other eminent panelists today. First, I will introduce with Prachi Madam. So Dr. Prachi Sathe. Actually, Madam is working in. Hi, ma'am.
No, I have joined, but my video is not on right now.
Okay, ma'am. Not an issue. So, Madam is.
Yes.
Madam is working intensivist, head of the department, and he's one of the teacher, and he's one of the great inspiration for all the critical care fellows. And under her care, I think there are a lot of research work is going on at Ruby Hall Hospital, Pune. So I welcome Madam to this episode of today's talk on these tropical infections and febrile illness of the monsoon. Hello, ma'am.
Thank you.
Yeah.
Thank you for inviting.
Thank you, ma'am. And with us also our other panelist, Dr. Nitin Rathod. Sir, Dr. Nitin Rathod, sir, is working as intensivist physician, Nanavati Hospital, Max Nanavati Hospital, Mumbai. And welcome, sir, to this session. I think sir is busy, so he'll be joining later on. And with us, our two other panelists, Dr. Achyut. Dr. Achyut is from Vizag, Apollo Hospital Chief Intensivist and leading critical care specialist from Apollo Hospital, Vizag. So he is with us. Hi, Dr. Achyut. And with us, my associate consultant, Dr. Swapnil. Dr. Swapnil is working in Apollo Hospital, Navi Mumbai, and he'll be one of the panelists. So with this, I think let's begin today's talk. So in the meantime, I just request Dr. Sagar to share the screen. Yeah, sorry for, and with us our ID specialist, Dr. Lakshman. So Dr. Lakshman is one of the leading infectious disease specialist around Navi Mumbai. So basically his vision in this area is very, very important. That's why we have called him here in this talk. And welcome, Dr. Lakshman.
Yeah, thank you very much, and looking forward to the talk.
Thank you. So, Dr. Sagar, can you share your slide? By the meantime, then the program will be started. Thank you.
Yeah, hi. Good evening, everyone. I hope my voice is audible and the screen share is on.
Oh, yes, very much. But can you make it in a slideshow, your PowerPoint presentation? Yeah.
Yes, I'll just do that. Right. Is that fine, sir?
Yes.
Yeah, that's fine.
Right. So good evening, everyone. Thank you to the Apollo team, Dr. Gunadhar, Dr. Akhilesh Saab, for giving me an opportunity to speak on the monsoon illnesses. So I am a physician originally, and this topic in particular is of great interest because I've done my undergraduation and my post-graduation from Navi Mumbai, which is the endemic hotspot of all the tropical illnesses. So in fact, our residency training largely, especially, was just dealing with all the tropical illnesses possible. Now, I believe a large focus of this is obviously directed to our junior colleagues who are in their critical care training. I'm glad that we have a lovely panel to moderate the session. Prachi Madam, of course, is a teacher to us all. So when we come to a tropical illness, and then it comes to the ED and then to the ICU. And here, especially with tropical illnesses, we must understand that a lot of this is to do with the basic MBBS level knowledge, what we learned in our MBBS training. So the clinical aspect is obviously the most important. However, since this talk is directed largely towards our postgraduates and our SS training colleagues, I will try to focus more on the modern aspects as well of these illnesses. So just to start with is a case which we dealt with a couple of years back. I mean, we've had many cases, but this was one interesting case because in a case like this, you eliminate the possibility of a clinical history. So we had a 27-year-old male. He was unresponsive, found naked with frothing of mouth on the road by the police. And the police just brought the patient to the ED of the hospital. And the ED, essentially, the patient was in shock with a GCS of 3. And I'm just talking about what you can possibly do in the ED. So the ECG was normal. He was hypoglycemic and he had a severe metabolic acidosis. And so at this point in time, you remove the possibility of any clinical history being taken. So, when we go to the differential diagnosis approach of fever, the history is eliminated. And essentially, because a clinical examination is very warranted, unfortunately, which is not done that well. However, assuming the fact that you start with this information, your typical labs are sent out. As you can see on day 1, patient had anemia, leukocytosis, a platelet count of 6,000, bilirubin of 13, and essentially the electrolytes, there is a bit of an injury. The creatinine is moderately elevated. But this is the key factor, right? Here you have the patient who is a case of malaria, and here you had a case of possibly a cerebral malaria. Of course, in a case to rule out environmental causes, toxins, there could be so many things, a road traffic accident. So of course, here everything was done in the ED. The CT showed cerebral edema, hypoglycemia was managed with dextrose 25. X-ray did not have any ARDS, and a USG showed a hepatosplenomegaly. I'm again repeating that this is what modern EDs do, which should not be the case. The clinical diagnosis would have already suggested a diagnosis of cerebral malaria. But the point here is that here in the first slide itself, you can understand that how a classical picture of a cerebral malaria may present to the ED. And of course, with gradual treatment, the patient gradually woke up. Obviously, he was mechanically ventilated, managed with anti-malarials. We even monitored the patient's parasitic index. And by day 4, day 5, he was extubated. Day 7, he was actually sent home. So again, this is the approach of an intensivist or a acute medicine approach to a tropical illness. So again, we have a classical case definition of a community onset undifferentiated fever, previously healthy, classical community, otherwise not recently ill, acute fever between 2 to 14 days. And again, very important that the patient has not had any prior treatment, especially with anti-malarials or antibiotics, because that may confound your picture later. These are the common bugs. Of course, what we call tropical fever, seasonal fever, monsoon fever, outbreak fever, tropical illness, all are very interchangeable words. Remember, and this is very crucial, that it all comes down to which area of the country we are practicing in. Malaria is spread across the country, so malaria has to be suspected. Dengue as well, especially when you have a rash or arthralgia. Leptospirosis, again, key clinical features, conjunctival suffusion, a muscle tenderness, more than bone tenderness, and jaundice. Typhoid, especially enteric fever, when you have a continuous fever and a gastrointestinal symptoms, as always, the classical ILI, influenza-like illnesses. Now, in medicine, we always think of horses and not zebras. In intensive care, we have to look for the zebras as well. So you can have scrub typhus with that classical painless eschar, lymphadenopathy, and a rash. Also, things like drug exposure, mononucleosis. And again, please do not always miss out a classical pneumonia or an intra-abdominal infection or sepsis. Hep A and Hep E are also normally indolent illnesses which have fever, and then you have secondary jaundice. Rheumatic fever, again, although it is extremely rare, it still does present in the underdeveloped parts of India. And of course, TB is always a possibility, especially for your long-standing patients. Now, I would like to start the approach with the ED. Of course, we have got the excellent guideline from the Indian Journal of Critical Care a couple of years back. Again, basic ABCs, get the red flags and observes. First, as a typical approach, rule out a focus of infection. That's your classical sources. You can think as per your sepsis approach. Then you move to a possibility of a clinical syndrome. Now here you have a very clear this thing. Again, they have emphasized that your geography and season is crucial. You have to first have a separate algorithm where you're talking about a fever with an encephalopathy. Now, fever with an encephalopathy warrants a slightly different approach. But most cases, you are going to have a fever with rash, fever with thrombocytopenia, fever with the hepatosplenomegaly, fever with jaundice, fever with ARDS, and fever with a multi-organ injury. Right. So let's look at the fever with encephalopathy. Again, the basics is managing the ABC, looking out of blood glucose. Again, that is basic management of the blood glucose. Again, second aspect is managing the hydration. This does not change for any patient in the ED. Obviously, if the patient is having seizure, administration of anti-epileptics. Now we come to need to rule out elevated ICP features or focal signs, and you need to start anti-ICP measures. We know the classical 1, 2, 3, 4, 5 approach. Then, of course, you may consider lumbar puncture and proceed with the basic CSF analysis, and you may proceed with a further workup depending on the very specific PCR analysis. You come to your basics, which is your ABG, CBC, electrolytes, hepatorenal function testing. EEG, not warranted for all situations. Then, of course, you've got your spot test where you have your malaria and you have your smears. If suggestive, artesunate to be administered immediately. And at the same time, somewhere neuroimaging also may not be done. And again, presumptive therapy here, ceftriaxone, SOS with the consideration of acyclovir, supportive care, evaluate, reevaluate, and then you work up for the others. Vidal, again, not a very strongly recommended test, but it can be used as a screening tool, or especially if you have a sequential Vidal. The serovars for typhus, lepto, and dengue, Japanese encephalitis, and herpes, and then you move to a targeted therapy. This is a very modern approach and a more practical approach. That being said, because if the patient gets to the ED and the ICU, you need to move a little bit more aggressive. That being said, we'll also start with the basics. So again, when you have a viral meningoencephalitis, or when you have a meningoencephalitis, you have infectious causes, and however, you can have a lot of non-infectious causes as well. It is possibly bacterial, viral, you can even get protozoal involvement. Again, and what we see in the ICU is most commonly for an inpatient to develop is septic encephalopathy. Regarding viral meningoencephalitis, there is a lovely differential, big list. Harrison has a list. The problem is that it is very region specific, and you are limited by the fact that the only viral encephalitis you can match, unless you want to make a research paper out of it, because the treatment doesn't really change. Largely here, when you're having an encephalopathy, the travel of the patient, there have been a few case reports of, in fact, our Indian travelers who have gone to the West with certain regions, with certain exposures, with West Nile, and come back and got hospitalized in Mumbai. And some of those young kids died with unknown viral meningoencephalitis. But again, that's very rare. Seasonal, of course, is a very important factor. Exposure to, the dairy products and brucellosis, again, rare. And of course, immunocompromised state, you need to take a very different approach. Classical sign of an encephalopathy, a meningoencephalitis, is your signs of meningitis. Here, I would like to make a point to my junior colleagues is that there is a difference between meningitis and meningism, right? Meningism is features of meningitis without actual inflammation. So you do get meningism with many of these illnesses, especially enteric fever. Key aspect, doesn't matter if you're having a meningism or a meningitis, what you need to rule out signs of ICP, cranial nerve involvement, rule out focal deficits, brainstem signs, and especially rarely flaccid paralysis. So of course, here lumbar puncture is warranted. Here you should be very careful in rushing for an LP. In certain cases where a CT is warranted prior to the LP, would be like an immunocompromised state, or with a seizure, or with papilledema, or with a severely compromised GCS or a focal deficit. The 5 things you need to be careful about before rushing in for a lumbar puncture in a patient with a febrile encephalopathy. Now, again, coming to the horses, not the zebras. What are the more common are tropical fevers with thrombocytopenia. So on the as you can see that in malaria, the platelet count gradually picks up. Enteric fever is a step ladder pattern. Dengue is a consistent drop. Lepto, it eventually picks up. Rickettsial disease, it picks up. And drug fever as well, it picks up. Again, the classical clinical aspects from chills, rigors, myalgias, retroorbital pain, headache, abdominal pain, diarrhea. Again, these are basic UG level approaches. But if I was examining the patient, I would start with this very table. And this is where my approach would start. If you have, especially now for the next 4 months, please do not forget your basic history. Please examine the abdomen for yourself. Please examine the conjunctiva for yourself, and then use your adjuncts in ultrasound. I know the ultrasound is more definitive. We all know the classical cutoffs, clinical features of splenomegaly and hepatomegaly. Then you've got your pericholecystic fluid collection and ascites, all can be picked up obviously on an ultrasound, but clinically you can make a faster diagnosis in under 3 minutes and know which particular tropical thrombocytopenic fever you are dealing with. Now, when we come down to the features, malaria and dengue largely can affect all systems. Leptospirosis in its nasty form affects the pulmonary, renal, or even liver injury. And that being said, enteric fever is more indolent. However, later it can turn severe. So you have an approach just with the thrombocytopenia. You have a organ-specific approach, and that is all which has to be combined into your approach. So these 2 slides are extremely important, the previous one and this one, because in these 2 slides, you can pretty much make your diagnosis. I will now be rushing through some of the slides, just a revision for our colleagues. Malaria, we know the 5 forms, very common in India. Anyone who's done their medicine residency knows that in your ward, you always had a microscope because you probably had to identify the parasite yourself. This remains gold standard. It's not only diagnostic, also the malarial index can be inferred from a direct examination. Obviously, nowadays we've got the rapid diagnostic tests. Again, these are tests depending whether you want to identify a falciparum or a non-falciparum species. These tests are, again, very important to discuss with your lab. What is the sensitivity and specificity of that particular test? The WHO has their list. The National Institute of Malaria Research in India has their list. It's important to know which card is being used in your hospital. So again, but most experts agree, most guidelines agree, if you have 2 negative tests, the likelihood of malaria is negative. Algorithm of malaria, very simple. Now, Vivax malaria is usually not said to be uncomplicated. We know that's not true. Essentially, the treatment is chloroquine for a simple case of Vivax malaria with primaquine. With falciparum, you have to go for artemisinin combined therapy. And yes, we all forget, but primaquine must be administered on day 2, even for cases of falciparum malaria. Of course, as we move ahead, when you don't have microscopy available, then probably the RDT is available. But as we know, the approach has changed because in the ED, you can probably do the RDT a lot faster. And now, very important, in no guideline, in no textbook, in the WHO or India, thrombocytopenia is not a complication of severe malaria. In fact, you have all of these: consciousness, convulsions, renal failure, jaundice, anemia less than 5, it's less than 7 in the Indian guideline, ARDS as well, hypoglycemia, acidosis, shock, DIC or algae malaria, hyperpyrexia require parenteral therapy for only these 10 conditions, which we know is not the case. Obviously, we want a rapid parasitic clearance of the parasite. So again, you need to be very careful about managing the malarial patient, but largely so, if you do a good job with the anti-malarials, the rest is very, very simple organ supportive care. A brief about the drugs, very important is that you will see a lot of variations in the treatment of artesunate. Please remember, it's not a 60 or 120 mg dose. It is 2.4 mg per kg body weight. Again, it's at 0, 12, 24, and then once a day. I see such discrepancy in the treatment, which is incorrect. No guideline recommends it. Quinine, an old popular drug, old timers still like it. However, artesunate has proven its efficacy over quinine. Only in select scenarios, you may consider quinine, which is of course pregnancy. That being said, the more recent data is strongly in favor of safety of artesunate in pregnancy. Artemether, again, not so popular, and arteether as well. Now we come to the most important illness, which is dengue. Now, dengue is a very important tropical fever illness. The reason why I want to cover dengue quickly is that dengue is a very classical tropical illness. It is the textbook tropical illness, which really requires a lot of intensive care management. We know it's a flavivirus, 4V serovars. We know the transmission is by the Aedes aegypti. It varies as well. Pathogenesis, again, largely dengue is an immune disease. So a lot of the sepsis protocols, except the antibiotics, basically fluid management is what we need to do in dengue. And dengue is one of the illnesses I strongly believe is the simplest to manage. And I think we overthink dengue. And if we follow dengue simple protocols, you'll have a very less mortality. That the dangerous phase of dengue is not the febrile phase. The dangerous phase of dengue is the phase in which you've got the post-febrile phase, where you have the possibility of shock and bleeding. That is where you have the possibility of hemoconcentration, and that is the real critical phase of dengue. Old classification of dengue is the undifferentiated fever, which starts from a fever, rash, signs of capillary leakage, and going all the way to a severe dengue fever. Classification has largely changed now. Of course, this is the original way we thought of dengue: DF, DF2, DF3, DF4, essentially progressing to a dengue shock syndrome. This is the one with the WHO has been advocating since 2014. What are the essentially trying to break dengue into three aspects: dengue, which is simple without warning signs, and dengue with warning signs, essentially categorizing severe dengue as a disease of plasma leakage, hemorrhage, or organ impairment. So there is a bit of a flux in which to approach dengue. This is a better clinical approach to look at dengue rather than just simplifying it with the old school thinking of a 1, 2, 3, 4 category as well. That being said, we all have seen dengue, vomiting, effusions. Basically, you have a state of serositis. And of course, the worrying phase of dengue is on the right-hand side, where you have a rising hematocrit, and you are going into a state of a dengue shock, which is the worrying aspect of dengue fever. And then you have the multi-organ storm, which follows. This is now the expanded dengue syndrome, again, which has all multi-organ involvement, and especially in cardiac as well, you can see a sense of myocarditis, and including ARDS. Of course, this, like I said, this is the classification of dengue, where largely you've got mild, moderate, or severe. Again, largely so, this is the original approach of where to manage dengue. It all depends on a dengue patient. Are you getting a dengue patient who has gone to hospital A, been partially treated? How was the fluid management done in dengue? Remains the most important aspect of dengue. There is no role of antimicrobials, no role of steroid therapy, only paracetamol and hydration, which is again, more importantly, which we will cover in the coming slide. Yeah, so like I again emphasize, you have the natural course, the febrile phase, which is the rash phase, the critical phase, which is the leakage phase, which is where your intensive care expertise comes in. And then, of course, you've got the convalescent phase. Dengue diagnosis, we know NS1 in the first 5 days, then day 4 onwards, the IgM can become positive. And you again have got rapid diagnostic tests. I again urge you with the RDTs, always be careful and know their sensitivity and specificity. The NS1 by ELISA is the best in the first 5 days. So again, like I said, largely so the management is rest, sponging, antipyretics, and mainstay is hydration. So this is an algorithm which I strongly feel, of course, we can run through the algorithm in detail, but my whole point of mentioning this algorithm is only one. That the key thing which you have to monitor in dengue is just the hematocrit, not just the hematocrit, but 90% of the management is on basis of the hematocrit. Yes, the platelet count is something which you should track, but the hematocrit is what you need to manage. And a lot of the management is on basis of the hematocrit. Again, a warning sign is rise by 20%. The whole point is that now this is a suggested algorithm. Obviously, in modern critical care, you have other methods to monitor as well, but largely so, all can be done easily. Now, when we come to a patient with DHF3 or going to DHF4, is where you need to be more careful about your fluid management, because here an excessive fluid administration may push the patient into a state of overload and cause more damage. Again, here you may necessarily consider the use of blood products. Similarly, if you're a DHF4, then you're going into a multi-organ strategy. If you have missed the bus where the hematocrit has risen and you have multi-organ, then you cannot make up for it after say 3 to 5 days. So this is that dangerous part of dengue. So it's very important when you start seeing the patient, the previous treatment details of your dengue patient remain the most important thing. Most ICUs calculated the cumulative fluid balances, but here your daily clinical examination, even for as simple something as seeing the patient's tongue, is a good marker of the hydration status. So rather than asking for a platelet count 12 hourly, I would rather be doing the hemodynamic volume assessment and the hematocrit evaluation 12 hourly for a critical dengue patient. Now, again, bleeding manifestations, it's very important that you can even, in fact, 10,000 is what some people agree. Corporates may have it at 20,000. Medical colleges still keep a threshold of 5,000. Key aspect is the platelet number may not correlate with the amount of bleeding. Largely the presence of hemorrhagic or hemorrhage at risk patients are the ones you need to be looking out for. Coming to the third disease I wanted to cover in slight detail is, of course, leptospirosis. We know it's a spirochete, direct skin contact. It's raining in Mumbai now. Probably in 3 weeks from now, we'll start seeing the hospitals full with lepto. Again, in Maharashtra especially, it's a serious issue. Again, with lepto is a unique disease because the problem with lepto is what we call the acute stage of fever. Then we have the convalescent stage. The problem with lepto is the problem of diagnosis of leptospirosis. You are not going to be able to diagnose a patient with leptospirosis in the first 3 to 5 days of illness. It is only after day 5 is where you have the commercial test largely available for diagnosing leptospirosis, because the antibody levels rise only after the first 5 days. However, lab investigations like blood and CSF and urine can be considered, but their yield is quite probably low. This is, of course, from the lepto guidelines from India. Here again, they have made it simple. You have anecteric leptospirosis, which is 90% of your cases who have fever, myalgia, and not jaundice. And then you've got the ecteric version, Weil's disease, the severe form jaundice with multi-organ, 5 to 10%. And then you've got the severe category presenting with pulmonary hemorrhage, which we see as a catastrophic complication. Anybody who's intubated a patient of pulmonary hemorrhage in the ICU with lepto knows how that is. It's one of the most traumatic things you'll probably go through during your training. Renal failure, respiratory failure, simple ARDS is manageable. However, the pulmonary hemorrhage of lepto is quite profound and severe, but again, not that common. So again, looking at some aspects, like I said, try to make it into 2 aspects, anecteric and ecteric, and then you have the severe one with multi-organ. Lab approach, like I said, culture isolation is difficult. The microscopic diagnosis is not so easy. Like I said, yields of 30 to 70%. Most commonly, we use the MAT test, which is positive usually after day 5, or a rising MAT-P is quite important. Management, like I said, is largely supportive. However, the diagnosis part is so one of the markers which you will see in lepto is a rising, or a raised CPK level. Cultures from the blood, CSF, urine, difficult to isolate, but the MAT test has a variable sensitivity. However, It's something which the IgM ELISA has a specificity of almost 95%. So approach, lepto less than 7 days, blood culture PCR, difficult yield, immune phase more than 5 days. You have a rapid test. And here again, if you have a MAT positive, you're not sure, you can obviously look at the titers. Now, again, conventional management is penicillin or cephalosporin or doxycycline. Now, in certain cases, you can talk about plasma exchange, corticosteroids, and IVIG. However, this is not recommended for 99.99% of the severe cases. Indian guidelines, very simple. And this is the most important drug in the next 4 months is doxycycline. The cheapest drug available, the best antibiotic, a simple doxycycline, 100 mg 12 hourly for 5 to 7 days. For lactating patients and for children less than 8, ampicillin 500 mg 6 hourly. Indian guidelines still recommend a dose of crystalline penicillin, 20 lakh units 6 hourly. An alternative is ceftriaxone or cefotaxime or even erythromycin. A lot of recent studies from Gujarat and Maharashtra have even suggested azithromycin as a great alternate macrolide. Coming now to the enteric type of illnesses, we know about enteric fever. It's a classical fecal-enteral transmission. You can have a large clinical feature. Now, again, with enteric fever, it has a phase 1, 2, and 3, first week, second week, third week, starting with non-specific illness like a fever, headache, relative bradycardia. Second week, where you get gastrointestinal features, and third week is injury management. Again, now this is, of course, you got the typhi dot test. Timing is very crucial. Vidal is quite useless according to me, especially in parts of Konkan and Mumbai. Blood culture remains the gold standard. Bone marrow culture is very sensitive, but not a commonly sought test. Simplest treatment, of course, is ceftriaxone at a full dose to cover for enteric fever. Quinolones have largely become resistant. Azithromycin at a higher dose is a great alternative. In select cases where I said when you have a enteric fever encephalopathy, and when you have a typhoid meningism or typhoid encephalopathy, a dexamethasone dose can be considered, but should probably be discussed with your ID or your neurophysician. Coming to the other fecal-oral illnesses, of course, you've got your Hep A. Of course, we know Hep A. I think everybody has seen Hep A and Hep B, where you have an indolent illness and the injury to the liver can be long-standing, and you can have patients. Very rare to see Hep A and Hep B in healthy patients, putting them in the ICU. Obviously, we know the exception to the rule is for a patient who is pregnant. Similarly, with Hep E is, of course, virus in the stool, which should be a better test in the initial part, and the IgM levels, which are later. Now we come to the zebras, of course, scrub typhus. Now with the prevalence of our travel industry, people are traveling a lot more. You have a scrub typhus presenting like an undifferentiated illness. Everybody loves looking for that eschar. Everybody likes looking for that wheel felix. That being said, doesn't matter because your doxycycline is the gold standard treatment, and you will likely treat with most patients with doxycycline. So it doesn't really change your treatment as much. So like I said, something, again, I apologize for my friends who are in different parts of the country. I believe in Karnataka, certain areas, scrub typhus is quite prevalent. But that being said, the treatment is quite simple. So doxy is your best friend in your monsoons. JEV parts, of course, we know of parts of Uttar Pradesh. And here you have the undifferentiated viral meningoencephalitis, classically presenting a fever with the encephalitis with extrapyramidal signs. And that is largely what you have to manage, which is supportive care and largely manage the seizures and the intracranial pressure. So just to revise, malaria all the way going to relapsing fever, you have on the left top of the screen is the classical features. Fever with rash, again, measles, largely in your children population, in some cases adults. Dengue, rickettsial disease. When you have a febrile encephalopathy, a cerebral malaria, a meningitis, or a meningoencephalitis. The fevers, of course, which worry us the most, and like I said, are the viral hemorrhagic fevers. Ebola and Lassa, of course, thankfully not reported in India, only confined to parts of Africa. Yellow fever, again, not in India. Dengue, very common. Meningococcemia, again, in certain high-risk population of a certain age group. Relapsing fevers, like I said, they can present with hemorrhages as well. Right. So to summarize, a malaria patient, fever with chills, hepatosplenomegaly, thrombocytopenia, simple diagnosis of your RDT, leptospirosis, incubation period is larger, a myalgia, fever. In a complicated case, you have a hepatorenal injury, worst case, a pulmonary hemorrhage. Dengue, again, shorter incubation period, which may present with a full spectrum of all your illnesses. So dengue must always be typhus, fever, myalgias, rash, looking for the Eshka, looking for lymph nodes and the ELISA for diagnosis. H1N1 and obviously COVID, we know all about it. Enteric fever, long incubation period. It's a prolonged illness and you can end up with a toxic shock syndrome. Pancytomania can present. Cultures are very important. Hantavirus problem is, I think a lot of people in Mumbai know hantavirus is there, but we've not been able to prove it serologically. So that's one of the very scary hemorrhagic fevers, which we have seen in the Mumbai region in medical colleges and in corporate hospitals. So, but very difficult to actually diagnose. This is of course from the ICCM, IGCCM guideline, fever with thrombocytopenia, basic principles, avoid anticoagulants, watch basic treatment, platelet transfusion less than 20,000, no role of steroids, fever with jaundice, ceftriaxone, doxycycline, fever with renal injury, again, ceftriaxone, doxy, fever with encephalopathy, consider IV acyclovir, manage the ICP. ARDS, of course, then you come to the specific management of ARDS. So thank you, everyone. I wanted to leave some time for the discussion, and I hope that I've been able to rapidly cover a lot of the tropical illnesses, and I look forward to the discussion ahead.
Yeah, thank you.
Wow.
Thank you, Dr. Sagar. I think you have covered so rapidly that actually I think it will be we would like to hear it in a very more in a prolonged duration of time. So anyway, it's a very interesting talk and a lot of informations are actually hidden inside it. So with this, let's go to the our panel discussion. We'll take the questions one by one.
So there is a question pertaining to the use of primaquine, the use in Vivax, and you have also mentioned the use in falciparum. How would we be justified using primaquine in these patients? This question is to you also, Dr. Sagar, and all the panelists. And I would like to know your experience of using primaquine in the your day-to-day practice as well.
Right. So, sir, the primaquine in falciparum is not for the patient. The primaquine actually is basically for the community. It's basically to kill the gametocytes so that the next person does not get infected with that patient. So the primaquine is not going to help that patient with falciparum, but the primaquine is meant to prevent the further spread to another patient who may get it. So it's not for the patient, but it's for the community.
Let's hear from Prachi madam.
Prachi madam, yeah. Madam, you are not audible.
You are
muted.
Right. So I think I would like to congratulate Dr. Sagar. You have really covered in great detail with a differential diagnosis. So that is nice.
Yes.
But there are just few things while listening to you which came to my mind as practical tips when we see the patients. Can I just share a few points?
Yes, ma'am.
Yes, ma'am.
Right. So you covered very well about fever and encephalopathy. So septic encephalopathy and actual involvement of the brain are two different things. And you explained it very well. I really appreciate that. Because in fevers like dengue, the involvement of the brain, initial period, it could be because of sepsis and dehydration on high-grade fever. Whereas in later part, it can be a part of dysregulated immunity where patient might be going towards something like HLH, which I'll talk about it slightly later. But all of us should understand, all the students should understand that encephalopathy is mainly a part of septic management, of septic manifestation of fever. All right. Then about malaria, you spoke a lot, which everybody must know, but it is good thing that incidence of malaria is going down significantly in India. Majorly what we are getting is dengue nowadays, rickettsia, and maybe leptospirosis. and hepatitis. History of travel, history of animal exposure, and history of insect bites is very important, and all of us should spend time bedside in taking this history. Serositis also you described very well. Capillary leak happens in most of the illnesses when there is severe sepsis, but dengue has its own kind of serositis, polyserositis. And it is so unfortunate that I have received a patient with acute abdomen-like syndrome with free fluid in abdomen, and they had even done an exploratory laparotomy outside, and patient just came and died. So we have to be very, very careful in diagnosing and interpreting free fluid collections in a tropical fever-like condition. When platelets are dropping, that also you explained very well about when to give and when not to give the platelet transfusions. There is one particular interpretation which we can do with immature platelet factors, which can become available nowadays in most of the laboratories. And if the IPF or immature platelet fraction is good, then we are not worried. We don't have to give platelets because it is already improving. Also, IPF tells us one more issue, whether it is peripheral destruction or whether there is manufacturing defect of platelets. Because in some complications, again, like where bone marrow gets affected in some types of dengue, there will be manufacturing which is reduced, whereas most of the times it is immune-related peripheral destruction. So IPF can be utilized well, and it can be used very well. Sorry, I'm just going, whatever points had come to my mind, I'm just mentioning. But we did not discuss much about lymphadenopathy. Agree, most of these fevers will not have lymphadenopathy, but sometimes undiagnosed fever which presents like tropical fever and has lymphadenopathy may point towards Epstein-Barr virus. And Epstein-Barr virus also has to be kept in mind in India because it can present and sometimes confuse us between these patients. About rapid diagnostics you were talking, Dr. Sagar. That is a PO panel kind of, BioFire, or the group of certain things becomes available, and it becomes very easy for a junior doctor, right? Just to order PO panel. PO panel, we have to understand, actually is a PCR based test, and it will become positive only if it's done very early in the fever phase. If a patient comes to a tertiary center after about 8 days, 10 days, sending PO panel is of no use, or it can be misleading actually. Right? And then there can be confusion between immune-based tests and PUO tests, because NS1, for let us take example of dengue. You said NS1 becomes positive till about 4 days, but sometimes it can go even up to 7 days. But before IgM develops, there can be a window period where nothing is positive. So clinically, we are suspecting dengue, but actually none of the tests can actually diagnose dengue for sure. So here, a senior or experienced viewpoint becomes important, and sometimes you may have to keep on repeating immune-based tests, right? Same thing is true about rickettsial fever. On day 1, you will never get those titers of wild Felix positive. It will start appearing only after a week. So clinical suspicion is extremely important. As you said, doxy is amrut. So you have to start giving doxy left, right, and center for any suspected tropical fever, no doubt about it. Just last 1 or 2 points. There is something called as HLH, and which we should not miss. You showed the classification of dengue fever, which has been propagated by WHO actually. But in that, it talks about dengue shock syndrome. If a patient is dropping platelets, also starts dropping WBC count, and then there is no correlation between drop in platelets and drop in WBC. One is rising, one is falling, or even all 3 cell lines are dropping. It is very important for us to do certain markers. Now, because of COVID, we have got used to all these markers like ferritin, LDH, IL-6, and we must use these, especially if it is an undiagnosed fever. Clinically, you suspect dengue, bone marrow showing suppression, high-grade fever, and altered sensorium of the patient. Occasionally, there is no shock. Actually, in these patients, there is no shock, but kidney gets involved, or there can be even myocardial involvement. So this HLH is a horrible place, horrible disease, and it can have a large spectrum. So it is a good thing to do these viral markers so that, like, warning signs, these also can be laboratory warning signs for us to note which dengue patient is going towards worsening of it. Okay. And just the last but not the least one point is like how we use doxy. Dexa is another thing. Where to use and where not to use is very important for all of us to understand. So if there is a rickettsial fever where there is involvement of brain, end vasculitis or end arteritis has already started taking place, then that is the drug which is going to save the patient or improve the patient, or even peripheral scar and the gangrene which is setting in. Second place is where HLH. HLH occurs not only in dengue, any type of fever HLH can happen. And that is one indication where we can successfully use Dexa. So I think with that, I would like to stop. What is coming in dengue? See, vaccine trials have been done for a long time. India, we really face dengue left, right, and center, and we lose so much of manpower and human life because of dengue. But vaccine has never become successful because there are 4 serotypes probably. But if once dengue has occurred and there is a second dengue infection, these patients are likely to become worse clinically because of dysregulated immunity, as it is called. But there is some good news, and that is there is a likelihood of availability of dengue antibody. And dengue antibody trials we are doing currently. In COVID, now we are all aware about availability of antibody. Similarly, dengue antibody is becoming available. Serum Institute has produced it. And if it is used in early phase, like 48 hours, it can actually reduce the chances of complications of dengue. So there is something to look forward to. I think I have taken too much of time. I would like to stop here, and I would really congratulate Dr. Gunadhar for choosing this topic at right time, and Dr. Sagar for presenting it so well. Thank you.
Thank you, ma'am. Thank you, ma'am, for the elaborative discussion. I would like to hear from Dr. Lakshman. What is actually the current guidelines recommended for at least the typhoid, the scrub typhus, the dengue, and malaria for our exam goers?
And I would also like to know about the availability of vaccines against malaria. What is the usefulness? And it is available in African countries. So what is the scope of its usefulness in Indian continent?
Yes, so I would like to say, yes, thank you. I would like to say that first is that when you see a tropical fever, you have to put it into a syndrome. So when you see a tropical infection, it is fever with thrombocytopenia, you have to consider malaria, dengue in those cases. When you have fever with hepatorenal involvement and jaundice, then you have to remember left tongue Mushy syndrome. So what is this left tongue Mushy syndrome? It's a mix of 3 diseases, which is left tongue is lepta, that is leptospirosis. Left tongue ang is basically the hantavirus, and Mushy is taken from Orientia susagamushi, which is nothing but scrub typhus. So if you see fever with jaundice and hepatorenal syndrome, you have to think of leptospirosis, you have to think of scrub typhus, and you have to think of hantavirus. Now, we have not been diagnosing so much of hantavirus because we do not have the PCR or the antibody test for it. But we see a lot of cases in our ICUs and even in the wards where patient has fever, hepatorenal involvement, jaundice, and we see that the other tests are negative. Malaria is negative, dengue is negative, lepto is negative. In those cases, you have to consider hantavirus. The treatment again is basically only symptomatic. And if you're suspecting scrub typhus, you need to do a scrub typhus IgM ELISA after 7 days of fever, which is more specific than your Weil-Felix test. So Weil-Felix test is similar to your Vidal test, which is actually outdated and not considered as the gold standard. What you require is a scrub typhus IgM. This is the way you consider fever with hepatorenal syndrome. Next will be a fever with encephalopathy or encephalitis syndrome, where you will consider dengue, enteric encephalopathy, or any viral meningoencephalitis and those things. So I think when you come across a case of tropical fever, you differentiate into different syndromes, and according to different syndromes, you come to various differential diagnosis and do the respective test as suggested. And as Prachima has rightly said, there is no role of steroids in dengue fever, as we all know. But if you see the WHO classification, it divides dengue fever into 3 parts. One is the mild dengue, which is only symptomatic treatment. Second is the dengue fever with warning signs, in which there is the serositis. As Dr. Sagar mentioned, patient will have abdominal pain, ascites, pleural effusion, and that is warning signs is important to note because patient may suddenly have a drop in the platelet count. And dengue fever is warning signs. Patient will not have fever. The fever part will have disappeared, and suddenly there will be a drop in the platelet count and serositis. So you have to identify the dengue with warning signs. And third is the dengue shock syndrome, which can either be a hemorrhagic fever when the patient has bleeding, or when the platelet counts is too low, less than 10,000, or patient may be in a shock state. So the fourth category which we see is basically dengue with HLH, where we see patients who have fever despite the 7-day period is over. So typically we don't see dengue fever for more than 7 to 8 days. If you see the WHO definition, it clearly mentions if there is a fever more than 8 days after having a dengue fever is ruled out. So if we many times we see dengue with HLH where the patient develops fever after day 8 or day 9 of fever, and along with that there will be all the 3 cell lines would be decreased. Hemoglobin will come down, WBC will come down, platelet will come down, and patient will have raised inflammatory markers like ferritin, fibrinogen, D dimers. This will be elevated. So that is the condition where you have to identify that probably now the patient is having dengue with HLH, and this is the only condition in dengue where steroids are recommended. Or probably even in encephalopathy, steroids can be given, but most likely dengue with with HLH is the only condition where you may consider giving steroids or consider giving immunoglobulin. Otherwise, there is no
Absolutely.
role of Otherwise there is no role of steroids in dengue. And regarding the malarial vaccines, as you rightly mentioned, malarial vaccines are being used in African countries. But again, we are not able to get a definitive malarial vaccine because there are 4 different types of malaria. As we know, the Vivax, Falciparum, Noel C. Because of the different variety of species of malaria, we are not having a single malarial vaccine that is effective. The same is the case with dengue vaccine as well. Because of the 4 different serovar types, we do not have one single vaccine which can work well. So I think there is still time for the vaccine to be used into for our routine purpose. In the meanwhile, but we have to monitor the signs and symptoms and make the appropriate clinical decisions, as Dr. Sagar has mentioned very elaborately.
Yeah.
So probably the role of monoclonal antibodies can be more, maybe available, in coming, years of time probably. As Madam has already said that there is definitely a role of monoclonal antibodies in complicated dengue. With probably we can prevent the complications. We can foresee and prevent the complications with the antibody, and probably that will help us. There are a few questions on the chat box. I would like to take these questions one by one. How do we prevent capillary leak syndrome, and how do we diagnose capillary leak, and what is the prompt treatment for capillary leak syndrome? So can I ask Dr. Swapnil, would you like to take this question and answer?
Swapnil, you are on mute. Anyway, if Rathod sir is there, Dr. Nitin Rathod sir, I think I would like to address this issue. Or Dr. Achyut. Okay, I think Madam can explain this, because I think it is one of the important aspects in critical care, because most of the times the patient succumb because of this. This is the only reason, I think.
Right. So it was mentioned by Dr. Sagar in his talk also. He has slides about capillary leak. So capillary leak, basically it is associated with glycocalyx damage at the epithelial level. And that is a part and parcel of PAMPs and DAMPs, as we are aware of, pathogen associated and damage associated interleukins, you can say. So it is basically a part of dysregulated immunity, as it is said. So one of the most important things to mend the damaged epithelium or glycocalyx is to give good amount of proper fluids. And that is one of the most important things in that is balanced fluids. So if we can maintain that, it cannot be completely reversed, but at least it would be controlled. And we have to stop giving fluids also at certain stage, because initial resuscitation is important, but positive fluid balance is not. If there is associated hyperferritinemia, hyper IL-6, that indicates that is hyperinflammatory zone where a small dose steroid can be used. And sepsis is not really bacterial sepsis alone. This also is a part and parcel of dengue-induced sepsis. So the same guidelines matter over here. Whether we should use albumin, because with this leak, albumin also goes out into the third space, especially the pleura and the ascites which is formed. Albumin can be utilized. As you know, there are large trials which have shown that albumin is safe, but that itself is not going to reverse the capillary leak, but it will help us to maintain circulatory volume, which itself is a repair mechanism for capillary leak.
Madam, regarding the role of hemofiltration, this is one of the important aspects in such cases. Can you just highlight, ma'am?
Right.
And role of CRRT also. Yeah.
Right. So we have been using extracorporeal therapies quite a lot in the ICU. We know the sepsis 3 definition defines sepsis as dysregulated immunity. We know there are pro and anti-inflammatory molecules which are being produced in the body. If both are of low concentration and they can negate each other or neutralize each other, it's well and good, the patient recovers. But if pro-inflammatory peak is very high, and similarly anti-inflammatory also is very high, like IL-6 and IL-10 studies we had done in our ICU. So both the peaks can be damaging and producing these multi-organ failures because of panepithelial involvement. So in early stage, if we can reduce these concentrations, then it is of great help to prevent these types of syndromes from progression. So cytokine removal can be done with an adsorber, which specifically removes certain molecular weight interleukins and cytokines from the body. It can be used like 12 hours to 24 hours. Most of the times, single or 2 columns are sufficient.
So the continuous renal replacement therapy will be more efficient in taking care of these inflammatory mediators, because these inflammatory mediators will be in pulses. There will be peaks and the troughs also. So if we are
the studies have shown that CRRT does not remove. It may help diluting or slightly reducing the concentrations, but they cannot remove selectively the cytokines. But overall dilution of the circulatory volume and replacing it with circulatory fresh fluids itself will reduce the brunt of all the cytokines. But they have tried high volume hemodiafiltration. They have tried plasmapheresis by replacement of plasma also, but they haven't shown any great benefit. But cytokine filters have.
What about the role of this cytosa filter? Because a lot of studies are actually failed to show any benefit in the clinical practice in such patients.
See, these not only cytosa, there are many filters actually like this. And in that, one definite finding is that it reduces the manifestations of sepsis. For example, inotropes come down significantly in a shocked patient. Now, whether that improves the mortality or not. So just by single parameter monitoring, we cannot judge that, because all these diseases are multifactorial. And probably because of that, it has not shown. Because when do you use it? We cannot say, like ECG changes can tell us when the myocardial infarction occurred. But we don't know when the dengue started and when it started going into decompensated phase. For example, whenever patient comes to us, for how long before that he was suffering, we don't know. So window period is like 24 to 48 hours. If we can apply these therapies within that short period, they are maximally beneficial. But if we apply it in a later stage, it may not show mortality benefit.
Another
there
question.
are multiple factors. Yeah. Okay.
Yes, so another very interesting question by Dr. Divya, based to all the panelists. Basically, I think I would like to take Madam to answer this question. Like most of the times we see dengue patients with raised WBC count, and sometimes it is confused with the secondary infection. So do these patients need to start on antibiotics in all the cases, or we should evaluate and then see for and then start with the antibiotics?
Most of the times we don't see high WBC count in dengue. It is dropping only. It may not be too bad or neutropenia like, but 2,300 and 2,500, 600, that kind of a zone you will see. If it is rising, I think it is better for us to check procalcitonin also before we make a decision about some very high antibiotic.
Because nowadays-
Otherwise,
Yes.
high WBC count is not a feature of dengue.
Yes. Because nowadays we are actually getting a lot of dengue cases from these nursing homes and peripheral hospitals, where after 5-6 days,
Nosocomial, yeah. They
yes.
So
already
dengue
have.
with secondary bacterial infections
It
can
It is
be
likely, yeah.
a likely cause. Yeah. So there is one question. Doxycycline is contraindicated in pregnancy and lactating females, and it is contraindicated in patients with age less than 8 years. So what will be the substitute for doxycycline in tropical infections? Dr. Sagar, would you like to take this question?
Dr.
I
Lakshman,
think,
Dr.
I think
Lakshman?
Lakshman is just replied. Lakshman, could you, I think, probably elaborate on that for the students, please? Yeah.
Yes. So doxycycline, what is the indication for doxycycline you are giving, that you have to consider. If you're considering giving doxycycline for scrub typhus in pregnancy, then don't give doxycycline, give azithromycin instead, which will cover it in pregnancy as well. If you're giving doxycycline for leptospirosis in pregnant ladies, then don't give doxycycline, instead give ceftriaxone or give crystalline penicillin. So there is an option available in pregnant ladies and in kids less than 8 years old where you cannot give doxycycline. Go for azithromycin or go for ceftriaxone or go for crystalline penicillin, depending on the tropical infection that you are suspecting.
So there are cases where we find that dengue is presenting with encephalopathy, and we keep doing lumbar puncture also, and lumbar puncture doesn't give you any idea. At times it is inconclusive. So, so what is the role of MRI, and how do we correlate the findings, and how do we differentiate it with other viral encephalopathy, especially when we want to rule out dengue encephalopathy? Any precise findings that we may be able to see in patients with the dengue encephalopathy in MRI? There is one question on this. So yeah, Dr. Sagar, Dr. Lakshman, Prachi madam, and
So
Dr.
I can
Swapnil.
just take this first. So first thing, we need to understand the difference between encephalopathy and an encephalitis. The key aspect is that there is a lovely table in Harrison, and you can find it online also, that when you have dengue encephalitis, there are about 4 or 5 viruses, and on the MRI, they have the classical signs. For example, with dengue, you have the first area to be involved is bilateral thalamic enhancement on the T2 and flare, if I'm not mistaken. So there, but it has to be true encephalitis for that to have actually developed, whereas an encephalopathy will have a clean MRI. So that is relatively rare. We're talking about the 1% of the 10% who are hospitalized.
Madam, your experience?
Yeah, actually, I don't think that MRI really contributes for diagnosis of encephalopathy of dengue. There are certain features which Dr. Sagar has already mentioned, but I think one of the major roles when the patient is deteriorating or neurologically not improving is to rule out the bleed. That also is one of the important things in dengue. Yeah.
So the clinical parameters, laboratory parameters, and the
That is the
biomarkers also
diagnosis, yeah.
should be able to guide you about encephalopathy. Yeah.
I'll just like to add that dengue encephalitis is very rare. So you getting a patient with dengue encephalitis is very rare, and there will be characteristic changes to be seen in the brain. Encephalopathy is more common in dengue patients, and MRI will be done more to rule out rather than rule in encephalopathy. So MRI will help you ruling out any bleed, any cerebral edema, and all those things. But dengue encephalitis will be more specific, and you will see those MRI findings.
So I would like to add here, just interestingly, we had an admission 3 days back, 18-year-old boy presenting with the classical dengue feature. Problem was he had meningism, and everybody got excited. You had the neuro, general medicine, gastro, he had liver dysfunction, and he was initially treated as a viral meningoencephalitis, received his dexamethasone, received ceftriaxone, acyclovir. Whereas in reality, he was just a case of simple severe dengue with encephalopathy. Now, the MRI was done in that super diagnostic haste within 12 hours, and all the patient required was just fluid management, and not everybody jumping to the idea of thinking of the zebra and the zebra. So, in critical care, we like to be the one to diagnose that one rare thing, but it's not. Like Madam also said, and Lakshman said, it's very uncommon. And it's that encephalopathy and encephalitis are two different entities.
So masterly inactivity and continuous evaluation, evaluation is more important rather than jumping to any particular treatment modality. That is what you want to convey.
I like the wording by Dr. Sagar, like monitor the tongue hydration 2 times in a day rather than monitoring the platelet count.
Yes, yes. That is an indirect marker of monitoring of the hematocrit as well.
So another question to Swapnil. So can you, Swapnil, tell to all our fellows, what is the routine role of antibiotics? It is asked by Dr. Preeti. Like most of the cases, we tend to start with meropenem when the patient comes to the ER, because some of them says it will cover leptospira, it will cover other things. So is it justified, or what do you think in this?
Thank you very much, sir, for asking such question and giving such platform for me. So basically, to start with, say or whatever we do is, yeah. Now, am I audible now?
Yes.
Okay, so basically to start with antibiotics, whenever a patient is in ER or we are seeing patient first time, we just start with broad spectrum antibiotics. As we don't know what is the underlying condition, but yeah, specifically speaking with meropenem, if patient is really having this compromised hemodynamic instability, or maybe something else, patient is received a higher antibiotics for some brief period from outside hospital, or patient is having recurrent infection, again directing towards this hemodynamic instability, then that time only we can start with meropenem, unless otherwise we have to always avoid such higher antibiotics, because it's a very high chance that organism might get resistance to this thing and we will again lose one antibiotic. That's the only thing I will say on it.
So there are instances where the patient is treated in the hospital, whether in the ICU or in the ward, and there is no diagnosis at all, and at the end in the discharge summary it is written as pyroxia of unknown origin. So
Yeah.
how relevant is this definition, and to diagnose somebody as PUO and discharge, and what is the relevance and what is the medical legal implication for that also? I mean, Prachi madam, I mean, you must have also encountered such situations where you couldn't diagnose malaria, dengue, or any kind of tropical infections, and you're sent the patient with the diagnosis of the PO. So how relevant is it, and what is the medical legal implication?
See, practically speaking, if we receive a patient after about 8 to 10 days or 14 days in some other hospital, the initial manifestations, classic manifestations which are required for diagnosis are gone. We have missed that window.
Yes.
Not only that, even the PUO panel test, PCR-based test will not tell us anything. So even if it is one of the common diagnoses, we will not be able to diagnose it probably. Maybe immune-based tests or titers of IgM will help us later on to diagnose it. So when one of the patients like that we were treating, we were literally repeating, clinically we were thinking it's dengue, and we were repeating IgM every 3rd, 4th day. And it did come positive after 1 week. So retrospectively, we could diagnose it as dengue. But when patients are talking ki wo kaun sa fever hai, and sometimes patients come to us, it is most stupid thing actually. वो बोलते कि वो malaria भी हो गया था, फिर typhoid भी हो गया था, because Vidal also was positive. And people don't know how to interpret the tests, and perhaps that is something which leads to these erroneous diagnoses, which we cannot diagnose. So undiagnosed fever can happen, unfortunately, because we have got very limited number of tests which we can do, but the organisms which infect human being are far more than that, and they change according to the stage of the disease in which they present to us and when we interact with the patient. So I don't think there is any medical legal implication to that. And sometimes there can be non-infectious fevers also, which we cannot deny. Or for example, Epstein-Barr virus, we cannot diagnose. We may not be able to diagnose, for example.
So how should we write as a diagnosis? Undifferentiated fever, or
undifferentiated fever, or viral fever, or pyrexia syndrome, or something like that.
Like one of the cases, we get one of the rare virus, madam, Crimean Congo hemorrhagic fever. So,
sorry, which one?
Crimean Congo hemorrhagic fever. So like that, thousands of viruses might be there. So,
whereas our testing armamentarium is very limited.
As far as diagnosis of malaria is also concerned, I mean, at times we find that, malarial antigen test is negative, rapid malarial antigen, we call it as, it is negative on, multiple times you keep on repeating it comes negative. So, and then you look at the parasite and microscopic examination also, it also becomes difficult to identify at times. So what is the best test to diagnose malaria?
Dr.
Dr.
Sagar.
Sagar, I mean, yeah, Dr. Sagar, Dr. Prachi Madam, and Dr. Lakshman. I mean,
Sir, I would
this is a
strongly
diagnostic
emphasize.
dilemma in most of the cases. I'm telling you, malaria gets undiagnosed. There will be classical picture of fever profile and all that, hemodynamic compromise and thrombocytopenia and liver dysfunction, everything you will see, but you don't get identified, as far as the organisms are concerned.
Sir,
Yeah.
here I strongly feel, sir, that the gold standard, you can always find the parasite under the microscope. And I will be very honest, we have a different generation of pathology teams because, like Madam said, malaria has been largely eliminated. In fact, during my residency, we did a random screen in our wards and we found out that everybody had the malarial parasite, even the stroke patient, even the diarrhea patient, because at that point, the malaria was so endemic in New Bombay, you had subclinical malaria in many of the patients. So the point is that your pathology team with regards to the microscopy can always be picked up. And sir, the rapid diagnostic test, I'll again say, sir, you have to find out what is the sensitivity of the specific kit which is being used in the lab, which is a very different aspect. So with the kit sensitivity and specificity, immediately the kits have also advanced. But that is my personal take, where I believe that malaria cannot be missed. I still believe that.
I'd like to just add one thing. There is this concept of clinical malaria in Mumbai, which is very common. And if you look into the BMC hospitals, almost every patient will be on ceftriaxone and artesunate. Now, this concept of clinical malaria is absolutely wrong. The WHO clearly mentions if you have two peripheral malarial smears which have been taken 12 hours apart and both of them are negative, malaria is ruled out. In addition to that, you have a rapid diagnostic test like an antigen test, which you can also do. But again, the drawback of antigen test is if you had malaria in the recent past, in the last 6 months, your antigen test will remain positive because that antigenemia would be present in the blood. So I would suggest if you're suspecting malaria, do two peripheral blood smears 12 hours apart. If it is negative, you have ruled out malaria. How to improve the yield of a malarial smear is basically you can do by QBC method, that is quantitative buffer coat. So that is not available in all the labs, but if you are going from a good labs, they will always centrifuge the sample, take the quantitative buffer coat, and then they will prepare a smear from it. And they will also mention the parasitic index. And you need to monitor the parasitic index as a prognostic factor for the treatment of malaria. So I think this concept of clinical malaria is wrong. We are overusing artesunate. And just as we've seen in cases of Cambodia, they are seeing artesunate resistant malarias, even P. vivax and falciparum resistant to your artesunate. If that kind of situation comes in Mumbai, we'll be having a huge number of challenge to it.
How about thick and thin smears? The relevance of thick and thin smears,
Yeah, so
Dr. Lakshman.
yeah, so thick and thin smears, the reason is to identify it. So thick smears will help you tell you whether it is malaria yes or malaria no. Thin smear will identify the species of malaria. So that is the importance of doing thick and thin smears. One will tell you whether malaria is there or not. Thin smear will identify in the telling you the species. For example, if you see a typical banana shaped gametocyte, you know that it is falciparum. Or if you see a vivax, you know that it is vivax. So that is why we say thick and thin smear. So as Sagar said, a good pathologist or a good microbiologist will be able to diagnose malaria looking at the smears.
What about the drug of choice in pregnancy with malaria, like severe malaria in pregnancy?
So I am still in favor of artesunate, and there are serious studies which suggest that artesunate is quite safe in pregnancy. Previously, the concept was that in pregnant women you should go for quinine. But as we have more and more data available, artesunate is good enough for pregnancy in any trimester of pregnancy. So nowadays we use artesunate because the complication of quinine therapy can be much more rather than the treatment with quinine therapy. So better to go for artesunate.
Okay.
Do you recommend artesunate and artemether in combination, or should be used
No,
as a
artesunate,
monotherapy?
it is basically artemisinin combination therapy. Now,
Yes.
artemisinin combination therapy can be either your artesunate or artemether. So if you have a sick patient, we go for IV artesunate as the dose mentioned, 2.4 milligram per kg. But whenever you give any artemisinin combination therapy, that is artesunate or artemether, you have to combine with a second agent because the artesunate gets rapidly resistant to malaria. So that is why whenever you're giving artesunate, you either combine it with doxycycline or combine it with clindamycin. If you are giving artemether, that what commonly we use Lumirax tablet on OPD patients. So again, when you're giving this Lumirax, when you're giving artemether, you combine it with another agent like lumefantrine. So the concept is never to give artemisinin as a single therapy, always give in combination.
Right. And do you routinely use this G6PD levels in all the patients before
Yes.
giving these drugs?
Yes.
All malaria patients.
Yes, yes. We use for all
Especially if
malaria
it is-
patients G6PD.
Especially if it is Vivax malaria, G6PD
For-
should be ruled
yeah.
out.
The reason being for falciparum, if we give primaquine, we are giving a single dose, that is 45 milligrams on the second day of illness. And that is, as Sagar mentioned, that is basically as a gametocidal agent. So that patient is not going to benefit from that primaquine, but it is a gametocidal agent. So if the patient takes primaquine 45 milligram on second day of illness, the mosquito which will bite him will not carry the gametocytes and will not be able to transfer to some other patient. But whereas for Vivax, we are giving primaquine as a hypnozoitic agent, so that to destroy all the parasite in the form of hypnozoites into the liver. So for that's why Vivax, especially we should do G6PD because we will be giving primaquine 15 milligrams per day for 14 days. So that's why I'll say more needed for G6PD, especially in Vivax patients.
Sir, and what
had-
about this primaquine in pregnancy?
I think that is debatable whether you can give primaquine in pregnancy or not, or whether you should switch to some other agents like mefloquine. So I would suggest that close monitoring is needed if you are especially considering primaquine in pregnancy. My personal opinion is that I have avoided primaquine in pregnant patients and just kept a close follow-up to see whether there is any malarial relapse or not.
Sir, and whenever we prescribe this primaquine, then there is a difference between that dosage of that particular medicine. I mean, base content of that tablet and salt content. So what we
Yeah,
have to
so
go at it?
the base content should be 7.5 milligram BD, that is up to 15 milligrams per day. That should be the base content of the primaquine.
In Vivax also?
That is for Vivax. For falciparum, you have to give 45 milligram of
This is
primaquine
one day.
as a single dose on day 2 of fever or of diagnosis of falciparum.
45 mg of base.
Base, the primaquine on the second day of P falciparum diagnosis.
Okay, okay.
Madam,
I
I
had
would like
seen one very innovative method of stopping the spread of malaria when the patient is hospitalized in a particular hospital. They had actually they practice this, that either dengue patient or malaria patient getting admitted in their hospital, they will put in the mosquito net so that there is no mosquito coming to him to take the infective agent to another patient. That was very innovative, I thought.
So there's one more question. There are situations where we find dengue and malaria coexisting together and contributing to the severity of illness. So is there any differential management strategy in such situations where you have both the tropical infections coexisting together and causing severe infection? Any particular strategy for coexisting infections?
Dr. Sagar?
I mean,
Sir,
you
so,
must have seen dengue with malaria, coming together and complicating things. So,
So the thing is that this part, that Occam's razor in medicine remains very true. Having a co-infection is still extremely, extremely rare. The reason I'll tell this to you is because although we may get the lab reports being positive, there are probably less than only 20 case reports in reputed journals which have actually verified from a standard source that that was actually the case. Many a times, and also we've got a concept of amnestic markers, which is an amnestic memory where you get a false positive reaction. So although we may have a dengue patient with the presence of the malarial parasite, that may not mean that the patient has malaria and dengue fever. So this amnestic markers, these amnestic reactions, very often we label as co-infections, or like Madam mentioned, the patient had dengue and malaria and typhoid. So the co-infection is actually a very rare aspect, honestly. However, probably propagated much more amongst and extremely, extremely rare. And I would not I would go by the clinical syndromic approach and the patient's pathophysiology rather than in this case focusing on a marker to say dengue and malaria together.
I think it's an overestimated thing because see the mode of transmission. Dengue fever is by Aedes aegypti, a mosquito which bites you early in the morning, whereas malaria is by an Anopheles mosquito which bites you in the night. Now you have to be very unfortunate that you get bitten by two different type of mosquito carrying two different agents into the body.
Absolutely.
So this co-infection is more because a patient may be a classical dengue fever, but his antigen test for malaria may come positive, for which actually he had malaria in the recent past. So people will say because his antigen test is positive and he is having all the features of dengue fever or dengue shock syndrome, so that is why it's a co-infection. So I would suggest that is basically a patient of dengue, which is much more common nowadays than malaria. So you probably treat for dengue, treat for symptomatic treatment, and just don't go by the lab reports that antigen is positive, so it is malaria. It has to fit in the clinical picture as well.
I
Very
have to,
similarly, there were some case reports that patients of COVID in Singapore or some country, I think, also had dengue. So
Yes.
that was amnestic reaction, as
And,
Dr. Sagar was.
and also typhoid, madam. Lot of patients of COVID, they are getting diagnosed with this typhoid positive.
No.
So that is also another finding. Madam, I have two questions in my WhatsApp. Basically, I would like to ask you. One is regarding the severe malaria and the critical care management. Like people have gone up to exchange transfusions if the parasitic index is more than 10 with multi-organ failure. So nowadays it is very rare to see such patients in the ICU. Like most of the times the malaria is, most of the patients, they get better with the current standard of treatment. So what do you really see such patients nowadays in your ICU, ma'am? And what is your protocol?
I have seen these patients like 20 years back, 20 years ago, where really
And
the
if I may
brown
add,
colored.
sorry.
Yes.
So to add that exchange transfusion, in fact, is a recommended strategy for pediatric patients, where severe pediatric patients with the HB of less than 5. So it is still a viable for pediatric. Again, I'm not that we do it at our center also, but in the last 5 years, probably for 2 patients that was done, but only in the pediatric population, not in the adult population.
Yeah.
I think
And
there are
for
lots of
HLH.
rouleau formation, and there is actually the brain circulation stops if there is parasites which are obstructing the microcirculation, and you are not left with anything else. So in such situations, these strategies are tried, but they haven't really proven much of benefit. But we don't see such severe malaria these days, and early diagnosis helps us, of course.
And one more question, madam, regarding the Zika virus infection and regarding the chikungunya infection, ma'am. I think we have not discussed about it. So
Yeah,
one of the
chikungunya.
friends, he wants to know
Chikungunya.
whether regarding
Let Dr. Lakshman talk about it.
Dr. Lakshman.
Yeah.
Zika.
So chikungunya, the typical manifestation would be fever associated with severe arthralgia. In some cases, you will see in addition to joint pains, there will be joint swellings as well, but there will not be any deformity of the joints which will be present. And typically chikungunya occurs in those typical belts. For example, in Maharashtra, there is a particular belt in which we see more chikungunya which occurs on those particular areas. So fever, joint pains, and it may be associated with thrombocytopenia. So chikungunya becomes a close differential diagnosis to dengue and Zika virus. Now in Zika virus also there will be a lot of joint pains which will be present. So Zika virus and chikungunya are often confused, but in Zika virus there will be conjunctivitis or a conjunctival congestion as well. So I think if you have a patient with fever and joint pains, make sure that you do the chikungunya IgM, but do it after 7 days of illness, because many a times IgM comes false negative if you do it too early. And the treatment for chikungunya would be just be symptomatic treatment, and the platelet drop would not be as severe as dengue fever. So there'll be mild thrombocytopenia which would recover as the illness progresses.
Yeah, absolutely right. But suppose we don't want to wait, or patient wants to know the diagnosis of, we should do a PCR, which is available
PCR,
for chikungunya in early stage. Otherwise, IgM comes positive much later.
Yes. So PCR test is available at Kastur.
I think
You're muted.
Mute.
Lakshman, you are on mute.
One more question is regarding the platelet transfusion, madam. Most of the centers, they prefer, sometimes they give platelet transfusion at a platelet count of 30,000. So what is exactly the guidelines in dengue basically? Because this is one of the burning problems in the current.
This was also mentioned by Dr. Sagar in one of his slides. Actually, internationally accepted is about 10,000 or below. But again, then there are certain caveats that if you are going to do, say, central line, you have to do, or some dialysis in a cannula insertion, surgery is out of question in these things. In that case, you have to maintain it something like 30 to 50,000 at least. But if patient is absolutely stable, you can even wait even up to 5,000 if there is no bleeding at all. And then I said that it is important to check immature platelet fraction. If it has started showing that the bone marrow has started producing and it is coming back again, then you can just take it little easy, rather than rushing for these, because it becomes like a horrible thing for patients' relatives. Every morning they'll come and ask, what is the count today? And whether we have to go for, preparing platelet transfusions and send somebody, and then it becomes a severe anxiety for them also. So we should not correlate exactly at single number, but correlate it with the clinical condition as well.
One more question, madam. Like, with dengue with HLH, what will be the best strategy? IVIG versus plasmapheresis. I mean, what is your experience?
My experience is that one thing is early picking up is required, so that these markers are very important in patients of dengue who are not settling like 4 days or 5 days, which was mentioned by Dr. Lakshman. If something persists till 7 days or beyond, like fever, encephalopathy, or counts, all 3 cell lines or at least 2 cell lines dipping, and then we have to check for the markers. And the best drug to start with is steroid, Dexa, rather than anything else. IVIG we have used in certain patients, but I have not found it of great use. And in fact, in certain patients, young patients who had organ involvement with HLH, etoposide we had used. And etoposide is also a very good drug which helps to reverse the syndrome of hemophagocytosis in dengue fever, or any HLH for that matter. In fact, even hepatitis E can give it, Epstein-Barr virus can give it, even in tuberculosis you can get it. So you have to have your antennas high.
Right. So I think we are coming to the end of the discussion with no more questions left. It is a definitely I mean it's a very good session, and I means all thanks all the panelists and speaker, Dr. Sagar, the panelist Prachi Madam, Dr. Lakshman, Dr. Swapnil, to present in today's session. And just to wind up, before we wind up, Madam, just a few take-home message if you like to give to our students regarding the exam preparation and regarding the how to means they go ahead with the or the means the study. So that,
they already look tired. A lot of people have started leaving. I think we are going beyond time.
Yes.
So exam preparation, I think I like what Dr. Jain used to say, treat your everyday as exam. So that exam is like your everyday.
Yes.
So, and never ever study in closed walls. Always, even if the exam comes closer now, at least do some of your duties, because looking at a patient and then reading helps you to remember lifelong. If you just sit on the table in closed room, you will forget.
Absolutely.
So correlate with your clinical experience. That is what matters.
Absolutely.
Dr. Sagar?
So for the students, I think ma'am has summated it quite well. I think I would just reiterate what ma'am said. I like, again, so being an intensivist does not mean that you are a clinician first. So I think that's very, very important. That's, I think, what ma'am has also emphasized, that bedside is everything. Bedside is everything. I agree with ma'am completely on that.
Yeah,
Dr. Lakshman? Dr. Lakshman?
I think he's
left, I think.
Yeah, Dr. Swapnil, what is your take-home message?
I will just say we should focus on clinical examination, not on daily basis, but starting from the day of admission, and what is the examination before a patient has come over here. Maybe patient has shifted from other hospital. Then we have to focus on that, and we have to jump on. Then we can come to some conclusion that will be definitely depending on this clinical examination only. Otherwise, the labs reports and all these things, all with the trend falling or increasing, that we have to take in a context and should just contribute to our diagnosis and obviously the treatment.
So evaluation, re-evaluation is very, very important.
Yeah.
Okay.
So thanking you all of you, ma'am, and Dr. Sagar and all the other panelists. So Every week, ma'am, next week we have an interesting session on 2D echo. So I would request everybody to be present and I'll send the link. Thank you, ma'am.
Thank you. Thank you, Dr. Gunadhar and
Thank
Dr.
you.
Akhilesh.
Thank you, ma'am.
madam. Thank you
Thanks,
very
Dr.
much.
Sagar. Nice meeting
Thank
you
you,
after a
Dr.
long time.
Sagar.
Thank you,
Yeah.
ma'am. Thank you,
Thank you.
everyone.
Thank you.
Thank you, Dr.
Thank you.
Swapnil.
Thank you, sir. Thank you, ma'am.
Okay,
Bye.
good
Thank you,
night.
sir.
Bye,
Good night.
all the participants.
Bye.
Thank
Thank you.
Bye.
Thank you.
Bye.
Good night.